All right, so we're on. So are we? You. So what I do now? We're being legal.
Hey guys.
Okay. Hey Lee.
Hey Lee, can you hear us?
Yeah, I know you're good.
We're
Are we live?
we are.
Okay.
Oh, you
Welcome everyone. This is Steve Love at the DFW Hospital Council, and we really appreciate everyone turning in. And it's my privilege now to turn this over to Lee Laverne, who is a past chair and president of the DFW HIMSS. Lee?
Thank you. So welcome everybody. And currently I'm right now the VP of Advocacy for the DFW HIMSS chapter. And I just want to say Happy Health IT Week to all of you, to every one of you. We really appreciate all you do to make healthcare better for all of us. The DFW HIMSS has partnered with the DFW Hospital Council to discuss the current national opioid crisis. So we're going to go through this presentation, and when you have questions, please go ahead and put them in the chat line, and we'll answer the questions at the end. Just if we could advance the next slide. I don't know, Steve, did you hear me?
Yeah, we're doing
Okay.
it. Hang on just a second.
Working through the mechanics.
Right.
None of that.
No, they did.
You got to fill
So just an end, so all the Texas chapters are getting together, and what we're doing is we're preparing to go to Austin on January 17th. So we will be asking for volunteers. We're going to go speak with our legislator, and one of the asks we're going to have is going to be opioid, and so we'll be soliciting for volunteers. This is a reminder here that if you're a member of HIMSS, go ahead and join. We have affiliate memberships that you can join the OA program and be a part of HIMSS. I'd like to go ahead and hand off to Steve Love so he can talk about the Dallas-Fort Worth Hospital Council, and also Dr. Michael Peterson, who's the Epidemic Solutions Lead for Accenture. And so thank you guys for preparing this presentation. Looking forward to it.
Thank you, and thank you very much. And to all the people that are on the webinar, we extend a special thank you to the DFW HIMSS chapter for partnering with us, and we appreciate all the hard work people have put into this very, very important presentation. As you know, the Hospital Council is made up of 90 hospitals here in North Texas, and we also have 90 associate members. So we are very appreciative for the educational sessions that we can do. And Dr. Peterson is really going to be the main presenter. I'm going to add a little information on public policy, but it's my privilege and pleasure to turn this now over to Dr. Peterson.
Thank you, Steve. I really appreciate it, and it's an absolute honor to be here. Happy Health IT Week to all our HIMSS compadres out there. Really, just when we talk about the opioid epidemic, it's kind of been in the news. There's a national perspective on it, and it has been incredibly devastating to the lives. So basically what I do for Accenture is the Epidemic Solutions Lead really means that I really like to solve complex problems or be a part of the solution to really solving them, one of them being the opioid epidemic. But we also do use data and analytics around trying to solve for infant mortality, maternal mortality, and mental health around suicide. So this opioid crisis has been obviously, as I said, just deeply impactful on our nation, and has been something that has been a struggle for a lot of states. People on this call have had some interaction or have at least third or fourth degree of separation as a touch point from the opioid crisis. This first slide really talks about the numbers, and we're going to just start detailing around the national numbers. And when I started doing this work a year ago, or first started talking about it, the number from the CDC a year ago was 91 deaths every day. And if you look at this number that says 774, that is probably underestimated as well. If you really think about that in terms of a visual perspective, think about an airplane crashing once a day. Now, if that really happened, the FAA, the government would mobilize and activate. No one would fly. This would be a huge issue. But when we speak of the opioid epidemic, we're talking about a substance use disorder sort of connected to a mental health issue that carries with it a huge stigma. And so the one thing I really would love to just kind of make sure everyone has a lasting message around is that we have to try to remove the stigma of this mental health problem if we're going to solve it. It's a devastating disease process, an epidemic. 72,000 people a year is estimated in 2016. The data is always going to be behind the actual. There's always a lag, but right now it's at 72,000, and it's expensive. The economic impact is $500 billion. That includes costs around point of care, patient care, but also included in the economic impact of loss of life and a lot of other costs that surround it. So, the number of people using it has increased and continues to grow. Although what I try to tell people is that right now we're talking about an opioid crisis, we have to think about in terms of how do we solve and use data to help solve for any crisis, and we're going to pivot to that in a few. But when you really think about the increase in deaths, right now we're talking about opioids, but there's been a surge in meth-related deaths that it's been laced with fentanyl, as well as cocaine is making a comeback, and they're have some unique population usages around that. And they think by 2025 it'll be 90,000, and it'll likely be more than that. Another piece of the impact is in my work, I travel around the United States and talking to Department of Health, Medicaid directors, different government and private payer entities, including hospital systems. And one thing that really, when we look at all these numbers, we have to remember that we're talking about people. And I've met a family in Kentucky that the gentleman lost his wife, his daughter, and his grandchild to this epidemic. It is eroding some communities in the Appalachian region where the epicenter started. So if you think Ohio, West Virginia, Indiana, and Kentucky, that's the hardest impact of this epidemic. And what has also happened is that children have been affected. So grandparents are now having to take care of their grandkids, and they're trying to do that on a fixed income. 92,000 kids are placed into foster care, and that's expensive for Medicaid and the states themselves, because when they go into foster care, the children automatically go into Medicaid as a ward of the state, and those numbers are devastating. And then, something around neonatal abstinence syndrome. I'm a pediatrician. I forgot to mention that piece. I did PZR for about 14 years. I went to med school in Houston, UT Med School, and then WashU for residency. And a lot of the babies I had to pick up most recently in a helicopter were these neonatal abstinence babies born dependent on opioids. So the mom was using and had a substance use disorder, and then the child was delivered. That's incredibly, so first off, there's 21,000 babies, but it's also incredibly expensive. The average cost of a baby in the hospital, depending on the length of stay, is between $55,000 and $200,000 if you add in an ICU care. So these children are born with a set of physiologic and neuro type of derivations that cause them to have to get either methadone or some sort of opioid to help curb the abstinence syndrome that's been caused by the opioid. The next slide is really an up-to-date sort of just a graphical representation of the devastating crisis. So if you look at the numbers and you just look at the main culprit of why people are dying has a lot to do with synthetic opioids. And these are shipped into the United States on the dark web and delivered to people's front doors, just like Amazon. Then they make the medicine, or sorry, the opioid pills, or put it into heroin. And the synthetic fentanyl is incredibly powerful, and like I said, it's the main culprit of cause of death. Fentanyl is, it only takes the weight of a snowflake in order for that drug to be effective. So if you think about these non-pharmaceutical, non-pharmacologic geniuses creating these pills and lacing about a gram of fentanyl, you can understand why people are dying. And it's also impacting first responders who are going into the field to resuscitate someone who's overdosed. And the synthetic fentanyl is so powerful that they're sometimes being exposed to the drug, and they themselves are needing a dose of Narcan or reversal. Again, you can see the trajectory of the deaths, and it's only going up as this crisis continues. So this is a great visual representation of the opioid epidemic. If you look, the epicenter is around that Appalachian region, around the corners of West Virginia, Ohio, Indiana, Kentucky. And you can see how over years, not only just deaths rising, but just the location of where people have died. The one thing I'll tell you about the opioid epidemic, if you already know, is that it doesn't have a racial or socioeconomic profile. There's no one immune to this. No one's inoculated from this crisis. The average opioid substance use person, person abusing opioids, is a 22-year-old white female, 23-year-old white male. Most of the people are getting, they start their introduction into the opioid crisis has been through either a dental procedure or an innocent sort of medical procedure, and then they, from that point, get addicted, and then they get cut off. And when they get cut off, that's where they generally go into the streets to try and get the drugs. So today's drug dealer doesn't meet them in the bad parts of town. They meet them at Starbucks, and that's where the middle class America is really getting their drugs. And with that, I'm going to give it back to Steve to give us the regional overview.
Yes, thank you very much, Dr. Peterson. And, we looked at some of the data that we have here at the Hospital Council, and from the third quarter of 2016 through the second quarter of 2018, we had almost 17,000 emergency room visits to North Texas hospitals that were due to opioid issues, but that was coded related to opioid. Many times coding is an issue because sometimes drug overdose or some other type of drug coding is used in lieu of opioid, so we really feel the number is much higher. So what are we looking at from a public policy point of view, and what are some of the things the state is doing? Well, just last month, many of the Texas criminal justice professionals really pushed in Austin for more options to fight opioid crisis. And there were hearings that were held, even though the legislative session's not in. But essentially, the criminal justice and child protective service professionals said that the state of Texas is severely lacking in services to combat the opioid crisis and other substance misuse problems. In fact, the Texas Health and Human Services Commission is continuing to push for more medication-assisted treatment options like methadone to treat opioid addiction. The director, Lisa Ramirez, said these services are particularly important to Texans getting out of jail, since they're more likely to die from an overdose in the very first week that they're released from jail. Also, the Texas Judicial Council surveyed 50 Texas judges and found that 70% of them were concerned from a moderate to a major concern about opioid use in Texas. A 13-member select committee made up of the legislature is looking at this problem since the last legislative session. And as you know, we convene a new legislative session this coming January. But we did see, just in the state of Texas, a 7.4% increase in opioid overdoses since 2016. So we hope that the upcoming legislative session, as it looks at mental health issues, substance misuse, can come up with solutions for Texas. Now, what's being done at the federal level? Well, let's look a little bit back at history. In March of 2017, the White House created the Commission on Combating Drug Addiction and the Opioid Epidemic. And many of you know that former New Jersey Governor Chris Christie headed up that commission. And even though the president proclaimed in October of 2017 that this was a public health emergency, those declarations do not allocate additional funding. They do obviously put a focus on it. On November the 1st, 2017, that commission sent a report to the president with 56 recommendations to combat the opioid crisis. Also, if you remember, in 2016, the 21st Century Cures Act and the Comprehensive Addiction and Recovery Act allocated about $1 billion to help fight the opioid epidemic. Many of these funds went to the Substance Abuse and Mental Health Administration and are available through state targeted response grants. However, the CDC received almost no additional funding. And when you look at the funding that's been used for opioid, it pales in comparison to the amount of funds that were given to the HIV epidemic when the country first had to deal with it. Unfortunately, something that also has arisen with the opioid epidemic, infectious diseases such as hepatitis B and C and HIV have risen dramatically in the last 5 years due to the intravenous drug use. Now, there are syringe service programs, and they have a proven track record to help local health departments contain these types of outbreaks. Unfortunately, though, due to federal regulations, they can only fund certain aspects of syringe service programs, but they are prohibited to use federal funds to purchase sterile needles. So we hope that one of the recommendations that came out of the commission was to lift the federal ban on purchasing those clean syringes. I think it was really summed up best by U.S. Representative Elijah Cummings from Maryland, who said, "We cannot fight this opioid epidemic without the funds needed to equal the challenges we face." Now, some good news also in rare bipartisan accord, and this is remarkable. The House and the Senate reached a compromise on the opioid bill that was pending in the Senate and the House. Recently, September the 28th, the House passed the compromise opioid bill 393 to 8. Again, 393 to 8. On October the 3rd, the Senate passed it 98 to 1. So as Dr. Peterson said, this isn't a Democratic problem or Republican problem. This is everyone's problem. And I think the fact that there was such bipartisan accord, this is going to help us. But this package is a 653-page bill, and it has a mix of law enforcement and public health measures, including one that prevents deadly opioids being imported through the mail. Now, you may say you could get opioids through the mail. Previously, you could. And another provision is it's going to make it easier for Medicaid recipients to get inpatient care for substance misuse over the next 5 years. But again, many people still say more funding is going to be needed. What is the status of this bill? It has been delivered to the president, and it is on the president's desk. And we assume and hope that he's going to sign it and enact it into law. And just so you know, the Congressional Budget Office, the CBO, has not scored this bill, but it is estimated, based on the Senate version, it's going to be $8 billion over 5 years. Now, don't get me wrong, $8 billion over 5 years is a lot of money, but it pales in comparison to the amount of money that was spent on HIV. This is going to improve in many ways the treatment for inpatient. As I mentioned earlier, Senator Rob Portman from Ohio, Dr. Peterson just mentioned that was a region of the country. He is the one that introduced in this bill that we needed to prohibit illicit opioids coming into this country through the mail. And so this will be in effect where hopefully 70% of all packages, especially those coming from other countries like China, will end. The bill also proposes that the FDA look at how they can dispense non-addictive painkillers in lieu of opioids. There was another portion of this that didn't go through. Senator Elizabeth Warren and also Elijah Cummings proposed that they model an opioid program similar to the Ryan White Act, which most of you know was used and is currently used to help fight HIV. Unfortunately, that did not pass. But there are some good parts to this bill that are going to deal with at-risk youth. It's also going to deal with foster youth. It's going to deal with non-opioid treatment options. It's going to have provisions that will help Medicare use telehealth services for opioid disorder, comprehensive screening for seniors. There are many seniors that are getting caught up in the opioid epidemic, and I could go on, but it is a comprehensive bipartisan bill. So where do we stand on this? Well, the hospitals, through the American Hospital Association, did put out on October the 3rd a press release that basically commended the House and the Senate for a bipartisan approach to address the opioid epidemic. And this actual compromise bill is known as the Patient and Communities Act, and we hope it's going to certainly help with substance use disorders. One thing we're particularly pleased with, it repealed partially the long-standing problem related to the Institutes of Mental Health exclusion, the IMD exclusion, and this is now going to give Medicaid through the state programs a chance to give up to 30 days of services for substance use disorder treatment for patients 21 through ages 64. Now, there's something that we wish had been in this compromise bill that was in the House version, but the Senate removed it. We still have got to work on how we can share patients' substance use disorder treatment information. Obviously, we have to comply with HIPAA, but there's a current law under 42 CFR that really undermines the ability of providers to effectively coordinate care for patients with substance use disorders. So we need to work on how we can share that information so we can improve the treatment for people, especially with opioid disorders. Is this a step in the right direction? Absolutely. But we have to continue to tell our federal legislators and our state legislators that this is an epidemic and we have got to address it as soon as possible in a fiscally responsible way. I'm now going to turn it back over to Dr. Peters.
Thank you, Steve. All incredibly great, incredible points. Recently I was at an HHS roundtable in DC with the Chief Technology Officer and Chief Data Officer, and they asked a group of people what was the one thing that needed to be done in order to really make progress in terms of the data, and it was unanimously altering the 42 CFR or modifying that policy, noting that HIPAA actually covers a lot of the things that the policy covers. So, kind of moving on, I'll share a story around a child I coded 4 years ago, just before I came into Accenture. Is a 15-year-old male who had overdosed on some fentanyl-laced heroin, and we did everything we could to resuscitate this child. And after the mom had, we had to call time of death. Watching a parent cry for their child is the hardest thing I think any physician has to do. But the mom came by about 3 or 4 months afterwards and sort of shared the story about how he had come into, she was thanking the staff, but said that he had gotten into opioids through his friends through his friend's parents' medicine cabinet. And it turns out that inadvertently we are all technically drug dealers, so to speak. If 50% of 50% of people on this call have a opioid or narcotic in their medicine cabinet right now that has been filled years ago or is a medicine they're not taking. So they've created these opioid drop boxes. But the point is, she said that he had gotten into that medicine from there. And then she further looked back and noted that he had gotten an injury and the orthopedic surgeon had prescribed him OxyContin. So he had already gotten addicted through an innocent touch point of a doctor trying to help. And so there's obviously a conversation around how do we, educate the physicians. But the key thing around what this poor mom had described was that she needed to talk about it. And the only way that we can really remove the stigma of addiction and substance use disorder and mental health is to have a conversation around it. And I thought that was that if you go to any opioid council, roundtable, summit, everyone talks about removing the stigma. And it's easier said than done, but the only way that we can do that is to really share stories and really have a more capable understanding.
If I could add one thing, you really touched on something there. 5 years ago, I went to have a root canal, and the dentist gave me 14 days of opioids. And of course, I just handed the prescription back to him and said, give me some Advil. But recently, just 2 weeks ago, there was a young lady that works here at the hospital council, had a root canal, and the dentist gave her 14 days of opioids. We've really got to educate people.
Yeah, there's some studies that show that people's touch points, not to rein in on dentists, that a large percentage of children, their first interaction with opioids is through the dental procedure, post operative care or post dental care. But we're all in the health space, and we all have a touch point to this epidemic. And since we are really talking about HIT, we were talking a little bit about how our philosophical view on how we can solve it using data. I always like to tell people that, I feel like everyone has analytics, but it's how you use the data. A little bit sort of the methodology of how we do it is more of like the Rosetta Stone to really try and solve and help governments, hospital systems, and the county and the city and even the communities, the community activist groups, the nonprofits deliver better precision care and services. And so, the key question is, how do we help them? How do we reduce this? One thing to remember is that the opioid crisis and substance use disorder in the epidemic is a multidimensional complex problem. You can't boil the ocean, and you can't use a shotgun approach. So you have to find a very specific use case and ask the right questions around data. And this data is flowing through your systems right now, through the hospital systems, through Medicaid, through public safety, foster care. All those systems are collecting all this data, but no one is really tying them together to help create a better understanding of the problem. The other thing I'd like to say is that the way we're going to solve this is through collaboration. It isn't going to be solved through one entity like Accenture or a hospital system. It has to be a collaborative private and government approach. So how do we reduce the economic impact? By moving towards this comprehensive approach that leverages technologies and drives insights to action. And sort of that's sort of like a mantra of ours, that insight-driven analytics and consulting. But the truth is, it does exist. We're not talking about rocket science here. There is the ability to get data and try to understand the problem. But the issue a lot of companies do is they provide heat maps, or they provide some basic generic visualization. And what our firm tries to do is we help our clients use that, not just the heat map, but get into what I call applied analytics, getting into the field and really driving action around that data. And that's really the exciting stuff that we're doing. So this is an example of you can't just get data for data's sake. There are some challenges, and some of these challenges are wrapped around, where's the data located? What data do I need? What use case am I trying to solve for? So where the data located, you'd be surprised. There are governments, I won't mention any names, agencies, state and federal, that have their data sitting in spreadsheets, or it's unstructured and sitting in actual paper. And I've heard these stories across the United States. Some states actually have a better data mindset, where they're absolutely digital, they're in the cloud, or they have some ability to really get to the data. But a lot of people spend time cleansing this data, and you can spend 75% trying to be precise, when really what you want to do in this space is to be directional. And then there are cultural, technological, and legal barriers to getting to the data and sharing it. A lot of it is cultural, believe it or not, and the data is complex. Because you can spend so much time, and some people think, I'll just do data for data's sake, that they're just spinning their wheels. So our goal is to pick a use case. One goal would be to pick a use case around getting the data to solve for that problem. So for instance, neonatal abstinence syndrome. We know who these moms are, because the greatest risk factor for delivering a baby with neonatal abstinence syndrome is to have already delivered one. So most likely that mom never got into therapy, or was tracked and followed to get the therapy, and so she delivered another baby. So they're in the claim system. They're a target population that's low-hanging fruit in order to develop some interventions around at the provider or hospital level, and at the state level through programs. This next picture is just really a representation of the fact of life. It's that siloed data conversation that everyone has an understanding around, but it's true, and it exists even in hospital systems. But this slide can be interchanged at the federal government level, the state level, using different entities. But the data does really sit in different spaces, and people are working in silos. So the example I will give, and we'll talk about it later, is in St. Louis, the fire department does not share their data with the police department, and neither of those two entities share the data with the public health department. That's around either Narcan reversal, opioid reversal with Narcan, interactions of people who come into the system. They're working in these silos, and each of them are interacting with a population of people who the data is getting dropped. And so what you want to do is create, have an analytics tool that can ingest all these different data sets and have a 360 view of the problem. Without that, you're really only going to solve a one-dimensional piece of the opioid epidemic. One thing I'll tell you is a lot of people have leaned on the PDMP, or the prescription monitoring software piece that a lot of the states require. The PDMPs are a tool, but they're not going to solve the problem. And one other thing to point out too is that there's been an internal sort of inertia of physician, prescribers, dentists, veterinarians, decreasing the amount of prescriptions internally. But we have the pendulum is swinging so up to the opposite end that people with actual true chronic pain are not getting the pain medications they need. So there is a middle that we need to get to. So what's this new data mindset? You know, you want to get to the data fast. You don't need to be perfect, but you want to be directional, and you want the data to be high quality and consistent. You can have a lot of really, I would say, unstructured, dirty data out there. If you think about just a simple ear infection into a hospital system EHR, that one interaction creates a lot of data. And so how do you get through all that noise of the data? So you have to really have the tools and the ability to sort of get the one piece of data you're looking for to precipitate to the top. And you want it to be fast, and you want it to be in a safe environment as well, and we'll get to that too. So this is an example of some data that we did ingest for a state client around just building a 360 view. So we used 31 data sets that were linked from 4 different agencies in the state of Ohio. And it was built around infant mortality, but you can interchange infant mortality with maternal mortality and or the opioid in terms of the data ingestion and analysis. Obviously the interventions are different, but the idea here is that the ability to take large data sets, big data, and the exciting things that you can draw from that, but it's the ability to put them into this platform and share all and get a better view of the patient. So an example would be, you know, a patient who has a touch point with Medicaid, the judicial system, in foster care, but they're also receiving food stamps, sort of on the WIC program and SNAP, and then they're also, you can build in the social determinants of health data as well to give you a better view of how to solve the problem by helping deliver the interventions that you want to deliver. But you can't just, again, ingest data for data's sake, and you have to do it incredibly safe. So the platform has to be FedRAMP, it has to be HIPAA compliant, you have to be able to anonymize and de-identify, and it needs to be secure, obviously with these privacy concerns. So that's some of the cool things that can be done around at least an analytics platform to really help solve the opioid epidemic. But remember, you want a use case, whether it be neonatal abstinence syndrome, whether it be prison recidivism, that fact around prison, you know, when they get out, they have 129% increase rate of death because they were receiving all the therapies that they were getting, you know, medication and through counseling in the prison system. When they get out, there's no wraparound services for them. So that use case really is a valid one that you can use data to try and reduce that and build better support services around them. The prison systems are the #1 health provider in the United States, believe it or not. So the next piece is I'm just going to share a couple stories around, and these are very simple visualization stories around how data can help tell a story or help to define some interventions. The interventions we want for the opioid epidemic have to be public health, evidence-based public health approaches that are, in my view, very precise, almost like a precisioned public health interventions, because each community has its own sort of fingerprint and differences street by street. So this here is a visualization of St. Louis, and this is just an example of how you can visualize from the opioid epidemic. This is actual medical examiner data around for I think it's 2 years. And the city had no clue. They knew they had deaths, They had 2 deaths a day, and they just needed help understanding where the deaths occurred and the time of death. And one thing Steve mentioned earlier was that was in one of his bullet points was that just keying in and coding the right deaths, the cause of death is a challenge, especially among medical examiners. So if you take a state like Kentucky that has over 101 counties, you have 101 different ways to identify and mark or code the cause of death. So that's why some of the numbers are underestimated. So back to St. Louis. What this data does is it really just gave them a really good story around the 2 years of actual deaths by what they call wards or districts, and where the deaths occurred. And what came out of this that was insightful was that a large percentage of the people, around almost 35%, actually came from out of the city and from the county into the city and actually died in the city. And you can break it down to what the cause of death. And so the other piece too that they found out was the location. And if we can't do this here, this is a sort of a static snapshot of this data. But when you click and you go over time, you can see where the majority of the deaths were and the time of deaths. And it turns out, in my view, agnostic, from just an anecdotal, I thought, well, people probably died at night. But it turns out they were dying at 10 a.m. And the data, as you click through, you can actually see down to the highway exit of where a lot of these deaths occurred. The next slide just really shows, again, the St. Louis Midwest metro area. This is St. Louis City specific, just the cause of death. And obviously, we had already described that fentanyl has especially synthetic fentanyl, is the significant cause for these increased deaths. And then here you're just looking at really heroin being a piece of it too. So if you layer all 3 of these, we recognize that it's heroin plus synthetic fentanyl that's causing a lot of these deaths. But so what? Well, the chief of police said, well, by looking at this data, I can already tell where I need to hotspot my police officers. The DEA said, you know what, we could put an undercover van and start collecting license plates at the time to understand when which vehicles came in and which one were suspicious. They tend to do that sometimes right now. The other intervention was, insight was, the hospital system said, you know what, we can predict when we may have a surge, or given that where the deaths occurred, where we might need to have an awareness of what could be coming in. The other thing to consider too is social determinants of health has become a buzzword, but it's really true. When we have these point of care interactions with patients, we don't often ask, are you food insecure, especially if they're Medicaid patients. We don't ask, do they have housing? If we do, it's collected, but there's no real way to really understand through an EHR where that story is told to help affect actually helping the patient that you're interacting with. So the idea is, social determinants of health are 60% of our health, and they really are impactful. So if you're trying to tell someone through an intervention or a conversation, hey, I want to get you into therapy, but you don't provide them the ride to the therapy, it's a fail from the beginning. And so we're realizing that the data around social determinants of health is really helping these states and the cities to develop interventions and a cocktail of interventions that are very specific to a very part of that community, because again, they're different. And I think that's important, especially as we're trying to solve using the data around who comes into the hospitals that we're seeing. Wouldn't it be great if the data could also tell you, almost like a FICO score, what your risk score for having substance use or risk factors towards becoming addicted. So it turns out if you're a mom who's post C-section, or if you're a gentleman who had back pain and you're prescribed an opioid, but you were also on a benzodiazepine or an anxiolytic, you have a 40-time increased risk of developing a substance use disorder. So wouldn't it be great to catch the people before they develop the addiction using data? So those are some examples. I'll end on one of my favorite quotes. Having gone to a lot of opioid summits, a lot of opioid roundtables and conferences, one thing I've noticed is that a lot of people talk about the problem, but no, there's very little action around it. And what I think this group, by the visit to the state legislature and through Steve's discussion and this example of using data, is that we, though Texas hasn't been hit as badly as the rest of the United States, we don't know when the asteroid could hit here around this problem. And, you know, all great and honorable actions are accompanied with great difficulties, and both must be enterprised and overcome by answerable courage. And so I encourage everybody to reach out through our contact information that's at the end of this if you have any questions, and let us know how we can help solve this. So I'm going to open this up for any questions.
Okay, Dr. Peterson, excuse me, you have a question. Can you provide a few examples of cultural barriers to data?
Absolutely. So again, not naming any entities, I will tell you that there are some entities, agencies at the federal level and at the state level who will quote policies that say I can't share with, and even at the city and county level. An example would be the city of St. Louis. I wasn't going to name, but I'll name it. The police department didn't know that they actually could share some data with the fire department. They just had this ingrained cultural viewpoint that was never allowed. In some state Medicaids, they don't know that they can share data. Now, it has to be the right data and get the right permissions. So one of the other barriers are these legal. And so they feel like culturally because they don't think they're allowed to share it, the policy says they can't, or they think the policy says they can't because that's just the way it's always been. They don't realize that if they actually involve legal and they actually talk to the other agencies, that barrier doesn't exist. So that's one example of a cultural barrier.
Do you have other questions?
I don't.
Okay. If there are any other questions, we'll be glad to try to field them. If you type them in, Chris is monitoring those. We'll be glad to do our best to try to answer them.
Okay, what is the impact of black tar heroin on the current crisis?
So that impact has been, I recommend everybody, I don't get a kickback, but I know the author really well. His name is Stan Quinones, and he wrote a book called Dreamland. And it's written as if you're watching Law and Order. He switches scenes, and he basically details in a very forensic, he's a LA Times reporter, of how black tar heroin came into the United States from Mexico, and how that business of delivering this black tar heroin was disrupted by these smart drug dealers, in that they figured out that a couple things they did. One was they would go to treatment centers and they would wait for people to come out, and then they would target those people to get them hooked back on their drug. The other thing they would do is the way they delivered the narcotics was to a Starbucks, because they knew that somebody wasn't going to drive to the bad part of town. So they really, from a marketing perspective, so that's the impact. So black tar heroin still has, it rears its ugly head. The drug dealers would put the drug in a balloon, and it would be just enough that if they got arrested, that they would, they knew the sort of the prison sentence or the sort of incarceration associated with it. So it would be just enough that they didn't have to go for a long time. It's a wonderful book. It's called Dreamland. You should read it. It's a good read.
Okay, well, we have another question.
Public school teen addiction, in-school programs as opposed to kicking player/student off the team and or kicking him or her out of school leads to drug use during the day. Habit to behavior to addiction. School administrators are in denial.
I think I understand where that's coming from. So we have to remind ourselves that substance use disorder is part of a larger mental health issue. And a lot of people, we come from a society, if you think about the United States consumes over 90% of the world's opioid supply. in terms of pharmaceutical narcotics. That's telling of our society in general, and whether that pain is emotional, physical, it's all derived, not all, but it can be derived from early childhood trauma, whether it be food insecurity, physical, sexual, physical abuse, those types of trauma. There are interesting conversations right now around how do we help. So the first thing is the conversation has to be around educating children at an early age, and there are a lot of great groups that do that. But the schools are, it's almost like the DARE program, but it has to be really tailored to a specific targeted age group that's at risk, and that is the adolescent. So that is a very good point. There are apps or at least I've heard of some apps and technologies that are wrapped around to help parents understand that their child might be at risk. But those things are still in development. But early education is absolutely key as one piece of helping solve this.
How big has the impact of Narcan been, and do our tax dollars go to first responders carrying Narcan? I have heard of some pharmacies that refuse to fill it.
I've not heard of that. Used to be about 3 or 4 years ago, where there were pharmacies that wouldn't give because Narcan was had to be prescribed. A lot of states have moved to creating the Medicaid director or the lead Department of Health commissioner has written what's called, they're usually physicians, has written a standing order so that Narcan can be picked up. There's federal funding for Narcan. The issue is the rate limiting step, or the capacitance issue, is wrapped around educating first responders on how to use it, and that costs money to do that. And then the other piece is delivering that Narcan to the right neighborhoods or the right entities. So that tends to become an issue as well. But you should be able to go in most states into any pharmacy and get Narcan. Ironically, though, as a point, some of the drug dealers are giving Narcan with the drug because they don't want to kill their customer. So they teach their person they're selling to how to resuscitate their customer so that they can keep them.
Do we have any more questions?
Well, we certainly want to thank everyone for participating on this webinar today, and special thanks to Lee again and the great work that the DFW HIMSS does. And Tiffany's here with us, and she's a board member. But we certainly want to thank Dr. Michael Peterson, who did an excellent job of updating us on the current status from a clinical point of view and a data point of view. The only thing that I would add, as you talk to people, whether it's at the state or federal level, explain to them, because you're their constituents, your keen concern about the opioid epidemic and how we together, as Dr. Peterson said, in a very collaborative spirit, we're not going to boil the ocean, but if we work together, we can do for this what was done with HIV, and we need to work collaboratively on it. So with that, do you have any closing remarks, Dr. Peterson?
No, I just want to thank you, Steve, and thank HIMSS for inviting me. It's an absolute pleasure to share the stories. This is a passion project of mine, and I get to use Accenture to help solve it. And we're deeply committed in the communities we work in. So thank you.
Okay, Tiffany, do you have any closing comments?
I think you guys have said it all.
Okay. Well, thank you all very much. And Chris, will this be, as far as the presentation, will that be posted on the website, or is that something that people can get?
Everyone registered for the webinar is going to receive the slides, and we'll also post a video on our YouTube channel.
Perfect. Well, thank you all very much, and I hope everyone has a great day.
Thank you.
Thanks, guys.